All right. Hello, everybody, and welcome to another deep dive session with Pega. Today, we're going to be taking a look at this 12-lead ECG. Of course, we're going to start off with a single channel and work it up to the full 12-lead. Now, my apologies. I'm a little bit sick, so if you hear me cough here and there and I forget to cut it out, my apologies. But let's get to it. So here we're looking at a single channel, right? So this is an ECG strip. The best you can hope for is to get a little rate, a little rhythm off of this. And of course, anytime anybody asks you the rate, you gotta think in your head, the rate of what, right? Rhythm, if we get lucky, maybe we'll figure something out here. Now, this looks like a very confusing, all over the place kind of an ECG, especially if you're new to this ECG interpretation world. And there's a lot of bizarre stuff going on here, right? The first thing that really stands out is this big hole here, right? There's this big hole with these little weird-looking waves there. There's an odd beat right there. There's another little pause, or at least it looks like a pause, right? And then we get another set of these waves over here. So just looking at this, I'm trying to really find a good starting point. And of course, you can always, go back on your method, and that's exactly what I'm trying to do in my head here. Where do I start? So I'm going to start with these few beats here at the beginning, right? These look pretty normal. These look pretty normal when I take a look at them from here to here. So this is just a quick eyeball to get the heart rate. We're looking at 300, 150, 175, 60. This goes in about 1/3 of the way in, between 75 and 60. So this heart rate here is roughly 70 beats per minute. Okay, so this heart rate is 70 beats per minute. We have 3 beats. There's a P wave in front of every single QRS. It's most likely normal sinus, but I'm just going to call it sinus rhythm. Okay. Again, in a single lead, if you get an upright P wave in lead 2, most of the time it is going to be something that's coming from the sinoatrial node, but can you guarantee it? Absolutely not. All right. Now, moving on. Let's take a look at the PR interval. The PR interval, I'm just going to grab it right here. Going to zoom in a little bit. Grab it right here. That is, I'd say, identical to that one. And it's almost identical to this one. This one is a little bit quicker. So this one happened a little bit more quickly, but I am not. So we might be looking at some sort of a block. Now, while I'm down here, this box you see over here starts off on this line. Here it bypasses this line. So this is bigger than one big box. Regardless of whether we have a higher degree block, we certainly have a first degree heart block. Okay, so far we also have, sinus rhythm 70, and we have a first degree AV block. Now, coming down at these funky looking waves, if you take a look at these waves and you're like, all right, these could be blocked PACs, or these could be some sort of atrial activity or whatever, to get the rate off of these here, we're looking at roughly 300, 150. This is maybe 220, 250 for this rate. So this heart rate here is like, this rate here is 250. Okay, roughly. Now, one thing that does correspond to this rate is atrial flutter. Okay, so we do have what appeared to be flutter waves. Now, I'm going to take this little box here. I haven't changed its dimensions. Just want to take a look at this. This looks about the same as the last one. This looks about the same as the last one. And then we run into this wide beat. Now, this QRS here, this is pretty normal, pretty narrow. However, this one here, now here we're running into a problem. This is like 200 milliseconds wide. It's probably less than that, but this is a wide beat, so this is most likely a PVC. Now this beat over here, I'm not seeing a P wave in front of it. Okay, so this could be junctional, but we're going to see when we get more channels involved what this is. There appears to be a little bit of a break, and then the rhythm resets. And let's see what the PR interval is like here. See how much measuring there is here? I mean, I'm really measuring stuff out. Yes, okay, partially this is an informative educational video, but this would be no different than if somebody handed this over to me. Now, this PR, I would say, is consistent with all other PR intervals with the exception of the first one. And then here, this one gets a little bit longer. So there is a little bit of movement when it comes to these PRs. Excuse me. And then we get some more flutter waves. Notice this one here. This is what the T wave typically looks like. It's very flat. So here we're getting that sawtooth pattern, and it's pretty obvious that these are indeed flutter waves. Now, we get a few of those, and then they disappear, and then the normal sinus rhythm or sinus rhythm reestablishes itself. So this is intermittent atrial flutter. Okay, it comes and goes. It comes and goes. And the good thing here is it's not sustaining, it's self-terminating, and it's self-terminating rather quickly. So the atrium is irritated. For what reason? I don't know. This patient was seen in the ER. A 12-lead ECG was taken. I have no demographic information about this patient. I know the patient was symptomatic. I don't know the symptoms. Now let's keep moving. Okay, so this little box here remained. Doesn't matter. What do we see here? First thing that really pops out is I was looking at this as a PVC, and here we can see that yes, indeed, this is a PVC, and this QRS is probably, what would that be, 160, let's say 160, 170 milliseconds wide. So this is, this is a PVC. Still, this beat afterwards remains a mystery, right? This beat remains a mystery, and we'll see when we get to a 12 lead if we can figure out what that is. So here we're looking at right V1 and V5, right side of the heart, left side of the heart. Exit pauses are clean in all the leads. We can see flutter waves in all of the leads as well. See that? So this is definitely flutter, and it's looking the way you would expect it to look. So for me, that is flutter. That has been confirmed. Intermittent flutter. All right, now we get to the 12 lead. Okie dokie. So let's reestablish what we know so far. We know that we have atrial flutter. It's intermittent. It comes and goes, right? It's there for a few. No, this person might feel this as quivering and a kind of a hollow feeling. I wouldn't be surprised if they mentioned something like that. What else do we know? We know that this is a PVC. We don't know what this is, so let's take a look at this. Oh, here's a clue. See this T wave as it comes down like so? See this little bulge here? A T wave will not do that. Not like that. So this bulge, I'm going to exaggerate here. It goes out and then it comes back in. A T wave will not do that. There's something hidden in there. Now if we follow this line up, there's a little bump right there. Difficult to see, but you know, as you train your eye, you'll see it. And there's another bump right here. Let me undo that. You can kind of see it here. Boom. It does that. So there's something hidden right there. Okay. And if this is a P wave, then this would be a normal beat. Now, why a normal beat? Well, first of all, it looks pretty much identical to, the rest of these QRSs, right? It's just looking very, very much like one of them. However, what's going on here is something that's called concealed conduction. So here, let's see, where's my heart? What was that? Left bundle, okay. So let's say this PVC goes off down here, right? The PVC goes off and it depolarized the ventricle. Now the signal is coming down from the atrium. That's your P wave, right? However, when it does penetrates the conductive system into the ventricles, however, here the system has been depolarized, and if we take a look at the ECG again, you see that it's coming at the end of the repolarization. So, right, depolarization, repolarization, it's coming in at the very end. So as it's progressing, some of this tissue here is coming back to normal, right? But it hasn't come back fully. So this signal, as it's coming down, has to wait. It's there. The biochemical process is going on, and it has a certain, how can I say this? It lingers for a little bit. It doesn't simply just get blocked and stops. There is a little bit of a delay, if you will. So what it's doing is it's slowly propagating as this tissue is becoming free, or as this tissue is repolarized. It's slowly propagating to it. It's slowly propagating to it until it can depolarize the ventricles. This is known as concealed conduction. And that's what you have going on here. So this is a normal, just a regular normal beat here, but we have a little bit of concealed conduction that's setting it off. So I'm just going to put up here CC, concealed conduction. I don't know, there's maybe an acronym for it, but for the purposes of this video, we're going to call it CC, right? Concealed conduction, but that is a normal beat. That's not a junctional anything. Okay, what else am I seeing on here? All right, so this really jumps out at me. Here we're talking about lead 1 and lead 2. Lead 1, the height of the QRS, the amplitude, is larger. It's obviously larger than lead 2. That should never happen. Not really. I mean, you can have instances where the heart is twisted a little bit, or maybe it's completely on the opposite side, right? You can have strange phenomena, but for all practical purposes, when we're talking about, things being normal, you should not have lead 1 QRS taller than lead 2. This would be indicative of left atrium, left arm and left leg leads being interchanged. Okay, so somebody slapped the left arm onto the left leg, and the left leg was slapped onto the left arm. All right, now this also confirms it. When this happens, as a consequence, oftentimes, not always, but oftentimes, you will see lead 3 having a predominantly negative and kind of small QRS signature, if you will. So I'm like 100% sure that this is left arm, left leg inversion here. What else? And because of this, now we bring into question, the rest of the ECG. Not so much the precordial stuff. However, your augments are going to be off. And here, AVR seems to be okay. AVL, I don't know. It was probably affected. To what degree, I guess we'll see. And AVF, they appear to be normal. We'll see in a little bit. I'll show you what another ECG on the same patient looks like in just a moment here. I just want to see what else I can pick off here. All right. Now this to me over here looks a little bit strange. Why do I say that? You could say that that's an S wave, but that's more like a dagger-like S wave. So you just get a straight shot down and up, right? Normally a wave will have a little bit of space between the sides. Here we don't. So we could be looking at maybe benign early repolarization here. We could be looking at a little bit of ST elevation of some sort. I'm not sure, but I don't like this. Now, again, this is really messing with us now. We have a lead inversion, and I don't know how much of the ECG in total that's affecting. But I want to show you. So this patient was taken when the patient arrived in the ER, right? The patient was symptomatic. And I'm going to show you now what the ECG looks like a couple hours later, but pay attention to this, please. Look at the size of this S wave. This is humongous. All right, now this is a PVC, right? Big deal, who cares, a PVC. An S wave or any amplitude on an ECG of this size, this is like, what, 5, 10, 15, 20, 30, 35. This is roughly 30, 35 millimeters of amplitude. This is huge. You need a lot of myocardial mass to produce this. And this is happening in lead V3. So this, if you think about where lead 3 is positioned, you're talking about the septum here. Anterior of the heart or the septum. And so there's something going on here. Something is definitely going on here. This patient is symptomatic. We're having intermittent atrial flutter. Okay, the leads are not working in our favor. But something else is going on here. Now let's take a look at what happened a couple hours later. Okay, so this is a couple. When I say a couple, I really have no idea. This was handed to me and just with no precise information. Okay, very, very little information, and so I'm just kind of working through this. But watch this. So this is a couple hours later. Let's say it's 2 hours later. Pay attention to lead 1, lead 2, and I really should have extended this down to lead 3, right? So look at this. Lead 1, lead 2, look how much taller it is, and lead 3. Look at lead 3. Here it's negative. It almost looks like a Q wave, right? Here it's completely positive. See how much of a difference lead inversion has made? So a couple hours later, this patient was placed, well, this was not a 12 lead, right? Here we're looking at lead 1, 2, 3, the augments, AVR, AVL, AVF, and then we have a couple of modified chest leads. This is lead V and MCL. Typically, they're assigned to monitor V1 and V5. Doesn't necessarily have to be the case. It can be any, depending on where you work at. And it's probably a good idea to know what they're trying to capture, V1, V2, V3. If you don't know, you're either going to have to ask somebody, or you're going to have to take a look at the patient's chest and see where the lead was placed. But sometimes the unit itself will do kind of funky analysis. And even though it's positioned at, for example, lead V4, it might be looking at trying to analyze V5. But good rule to follow, take a look at the patient, see where that electrode is placed, that V electrode or MCL. They should be labeled as such. And you should get an idea of what it is that you're looking at here, okay? Now, let's keep going. So with this patient, we still have atrial flutter, right? It's intermittent. Now, I do want to point this out. This over here looks like a regular P wave. Maybe it is, maybe it's not. The reason why I say this is a regular P wave is because the PR interval here appears to be the same as over here, and every time we get a QRS to depolarize, we are excuse me, the PR interval is the same every time we get this to depolarize. That's one thing. Another thing that's interesting here is the here not right here. See here the flutter waves are just kind of kicking in, and here we're getting typical sawtooth pattern with ventricular depolarization. But here prior to this, the PR interval is always the same. So this is the first atrial depolarization that sets off these intermittent bursts of atrial flutter. Now, another thing, if you're thinking this could be a block, look at the ventricular response. It's not regular. It's irregular. Okay, so this is not a complete heart block of some sort. Okie dokie, let's keep moving. We do have exit pauses, right? So the and by the way, these are two different times, right? This is not this ECG on a different machine. This happened a couple hours before this one. All right. Now, AVR is inverted. It is huge. Lead 2 is huge. AVF is huge. Let's see here. AVL is isoelectric. So there's something is going on with this patient. And let's see, what else do we have here? Look at this now. Now these are modified chest leads. Let's go back to the 12 lead here. Here in the 12 lead, we're not getting any ST elevation. Not really. Maybe it's subtle. Okay, maybe there is something going on here, but it's very, very subtle to the point where you can ignore it. Well, maybe not. We might have a little box here in V3. See, I didn't catch that the first time. Right. Now, when you take a look at it here, maybe this is the cleanest example. Whoops. Oh, I'm sorry, guys. Here we're getting quite a bit of ST elevation. Now these flutter waves, right, they're going to mess with everything. They're going to push and pull regular segments either up or down. They're going to add to the T wave. They're going to take away from the ST segment. But look at this. In every single beat, the ST segment here is has been increased, has been elevated, right? So there is ST elevation going on here. In which lead? Don't know. Probably V1, V2, but maybe this is V3 and V4. It, judging from the morphology of the QRS, I would say that this is, V1 through V3. You would not expect to have this sort of morphology in leads 5 and 6. But this is most likely pertaining to the right side of the heart. Anytime you mention the right side of the heart, you can also think about the inferior side of the heart. And when we take a look at the inferior leads, which are leads 2, 3, and AVF, whoops, look at this. It looks like we're having a little bit of ST depression. So it looks like we're having a little bit of ST depression going on here. Here it's very subtle. And yes, indeed, this patient, I don't know, they could be having some sort of an intermittent spasm. So one of the blood vessels is under stress for whatever reason, and it's constricting the blood flow, and this is maybe what's causing the atrial flutter. It could be that, this person is having a blockage, and this could progress to a full myocardial infarction. That could happen. But what else? What else here? I'm missing something. Oh yeah, how could I miss that? So remember this PVC. I talked about how huge this is, right? Now, looking at this, looking at this and to try and confirm LVH or RVH, hypertrophy of any kind, which I was kind of suspecting with that PVC, you would need leads V1 and V5 and V6 for Sokolov-Lyon criteria. We don't have that. But looking at this V here, and I'm just going to take a look at this and try and figure out how deep this is. This is 5, 10, 15, 20, 25, 30, maybe 33. For V1. And why did I go down here? See how this line right here is very, very dark, and then we have a clear S wave from the other lead. That's why I drew it from there to there. Lead 2 is also huge, right? So if we take a look at lead 2, we're going to take a look at it a little more precisely. Here's my what is this, PR segment, and we're going up here to the peak of the R wave. This is 5, 10, 15, 20, 25, 30. This is roughly 30 millimeters of height. Now, I can't use Sokolov-Lyon criteria. However, there are standalone criteria, which get a little bit tricky, okay? With standalone criteria, you can't just say, okay, boom, you have LVH. You can say, I strongly suspect it. And at this point, I'm going to say that we strongly suspect that this person has LVH. So this person would probably benefit from an echo, okay? Get an echo done and see if there really indeed is some sort of left ventricular hypertrophy here. This goes for lead 2, and this goes for this modified lead down here. Now, another thing that I was kind of looking at while I was measuring down here, these P waves here are pretty big. Now, I can't clearly see what's going on here, but remember, if you can fit a small box into a P wave, you have some sort of right atrial enlargement. Right atrial, your P wave is just going to look big. If you can fit a small box inside of it, you have some sort of enlargement. Your left atrial enlargement is just going to be a wide P wave, and it can also be both, where the latter portion is going to be, larger than the first portion. There's of course gray areas. Not all of this stuff is going to look textbook perfect, so you do have to kind of think your way through it. But we might have right atrial enlargement here as well. Now, when we put all of that together, we have some sort of strain going on here, right? There's ST elevation. We most likely have LVH. We most likely have right atrial enlargement. Right atrial enlargement will give you cause to see atrial flutter. So any atrial enlargement, any atrial anomalies of any kind, you're looking at possible fibrillation, you're looking at possible flutter, you're looking at possible atrial tachycardias. So the atrium is going to be irritated, PACs, so on and so forth, right? So now the picture is starting to make a lot more sense. This person might have an enlarged atrium, which is giving this intermittent, what do you call it, atrial flutter. This person might have an enlargement in one of the ventricles, most likely LVH. This could also be septal, And the reason I say that is, let's see here. Do I have it here? Yeah. So if we take a look at this, actually, let me go to a different screen. Where is that? Here. If we take a look at that, right? So here's your lead 2. Here's your lead 2. Excuse me, no, that's V2. I want to take a look at lead 2. Lead 2 had an enormous signal, all right? Compared to lead 3 and AVF, it had an enormous signal. So as that signal, and really lead 2 is looking at everything from up here all the way down to the apex of the heart, right? So if you have an enormous signal there, that means there's a lot of mass here that's giving rise to that depolarization. So you're probably looking at some sort of an enlargement. Okay. While, for example, if you take a look at lead 3, right, it's going to be covering much less of the heart. So you would expect to see a smaller QRS signature. Now, if we go back to the ECG, what do we see? Lead 2, the signal is humongous. Lead 3, significantly smaller. So yes, indeed, I would say that this person does have some sort of hypertrophy, and they would benefit from an echo. Now, I don't have any more information from this patient. It does look like they're undergoing some sort of cardiovascular strain here. What happened to them? Was this an MI? Was it an occluded artery? What happened? I have no idea. I'm just looking at the ECG here and trying to piece together as much information as possible. And I think we're going to hang it up right there for the deep dive. I think I've blabbed on enough, and my throat is pretty dry. So thank you guys for joining us this week. Hopefully you learned something, and we will see you next week.